from the beginning. I don't know if anyone heard the little introduction. I don't think the microphone was on. Should I start again? Start again.
Yeah, no. Yeah, start.
So yeah, I was just saying really this talk, I'm just giving a quick overview of what I was going to do, which was just recap on ccTGA, which we have been talking about now for a couple of weeks, and then focusing on the adult patient. So looking at how ccTGA presents, and then the problems that adult patients have, and looking at the pathophysiology behind that, and then a little bit on the management of the problems they have, and ending really with a focus on the European guidelines for follow-up for adult patients. So the recap to begin with, which I'm sure after the last few weeks is all quite clear. Everyone's probably got a good grasp of ccTGA, but it's not very common. It's probably 0.5 to 1% of all congenital heart disease that we see. Its name kind of explains what it is in a way, congenitally corrected transposition. So some people use phrases like double disc concordance or physiologically corrected. It basically means that there's atrioventricular discordance and ventricular arterial discordance. So that means the patient will be not presenting with cyanosis and things that you would see with normal TGA. Along with that, it's not really a very it's quite heterogeneous in the way it presents, and there can be multiple different associations. So usually the atria are situs, and a small percentage they might not be. You might have mirror image atria as well. And then the actual orientation of the cardiac orientation can be mesocardiac, but then you can have dextrocardia or levocardia. And it's common to have associated lesions. Well over half will have that. So VSD is probably one of the commonest associations, and then pulmonary stenosis occurs in quite a number as well. And then also the tricuspid valve itself can be abnormal, so it can be like an Epstein's valve, but not quite the same as you would see in a normal right-sided right ventricle. It can be epstenoid, and it can be abnormal in other ways. And the other feature of ccTGA is that there's some malalignment of the septum, usually from the atrial septum and the ventricular septum. So that means that that's where the conducting system is. So that predisposes them to conduction abnormalities, and they can be quite common. And that just is a kind of quick echo picture on the side showing the orientation of the vessel. So you often will have the pulmonary artery posterior, which is what that's showing. So with that kind of wide variety of in one condition, as I say, there's quite a wide spectrum of anatomy. The way it presents really depends on the associated abnormalities. So if you've got a large VSD, these cases might present quite early in infancy with failure. And if there's pulmonary stenosis, there might be cyanose. It's really the isolated ccTGA which kind of goes undetected sometimes until quite late in life. It may be that there's clues in a chest X-ray. The chest X-ray in isolated ccTGA, the mediastinum will be different with a straighter, like left side. Or there can be things that alert you to on the ECG. There's some typical findings on the ECG, and there's also, if there's dextrocardia, that might flag up prompt some further investigations. If nothing like that comes to light, it might be when symptoms present, so that can be later on in life, and that's usually to do with a systemic right ventricle rather than a left ventricle, so that gives you symptoms of failure. And it can also be because the valve on the left side is actually a tricuspid, and that can become regurgitant, and that's probably what I'm going to focus on a bit in this talk, really. And then the other thing is arrhythmia, because as I said, they're predisposed to conduction problems and other arrhythmias for other reasons, which I'll also touch on. So just a quick ECG, which would probably prompt you to think there's dextrocardia, and maybe then prompts an echo, right axis deviation, and then the big clues are that the lead one is all negative, or the QRS is inverted, whereas AVR is positive, and then obviously there's the R-wave progression in the chest leads is not there, so that's prompts you to think of dextrocardia, hopefully. More if there's levocardia, the ECG still will have signs because of the fact that the conduction pathway is not normal. So where you might have key waves in V5 and V6, they'll be absent, but you might have some in V1, and you can see the axis will be abnormal again, and then there may be other clues, like if there's pre-excitation or heart block, that might prompt you to investigate. So that's one way they can present. When you do the echo, then the main feature is offsetting the valves is lost because the ventricles are inverted. So your left ventricle, morphological left ventricle, I'll call it, is on the right. So that means your mitral valve is also on the right. So that will be higher than the valve with the right ventricle on the left. So that this echo is like extreme, but would be easier to notice, I guess, because the valve's obviously epistenoid as well and quite low down in the ventricle. Otherwise, it could be a bit more subtle, but you might also notice the ventricle is, trabeculated as a right ventricle, but on the left. So it becomes confusing with terminology, but the easiest way to manage that is by referring to the morphological right and left ventricle. So in this case, the morphological right ventricle is on the left, just for clarity, and the morphological left ventricle is on the right. And as we know, the valves are with the ventricle, so you've got a mitral valve on the right. Adult patients, as I say, they're quite a heterogeneous group of patients. They may have been operated on, they may not. They may have been diagnosed after adolescence or into the third or fourth decade even. So that means they're quite different in their management and follow-up. From about 1960 onwards, I think if a patient was known to have ccTGA, they would undergo some degree of surgical palliation, but they wouldn't have a anatomical repair, meaning that they wouldn't be, like now we might do a double switch and then you are restoring your left ventricle to be, the morphological left ventricle to be the systemic ventricle. With a physiological repair, which was the first types of surgery done, the issue is that your ventricle, your systemic ventricle, is going to be your morphologically right ventricle, and that's just not an ideal situation, which is what we'll go into a bit more. So from 1990 onwards, more anatomical corrections were done, so double switches, etc. This means that I suppose as time goes on, the follow-up, the group of patients we're following up might present differently, but there's still going to be patients who either were undetected or for some reason were not suitable for an anatomic repair, and so they still have a systemic right ventricle. And because time limitation and perhaps also my own knowledge limitation, I thought I'd focus more on the management and follow-up of patients with a systemic right ventricle in this talk. So when I did approach our two cardiologists who do some ACHD clinics and asked them about the follow-up and patients they had and if they had any interesting cases, and both of them straight away said, "Oh, I've got a patient." One, I think Dr. Johnson trumped Dr. Peer. He mentioned a patient in the 70s who has never had a repair, has a systemic right ventricle, and is doing really well, apart from the usual, old age associated decline, has done great. And Dr. Peer again mentioned someone in her 60s with really good RV function, but I think this is absolutely the exception, and probably just is clear in their mind because of that fact. It's the exception, because normally as early as first or second decade, these patients will run into problems, and definitely by fifth, sixth decade. And this is just a progressive problem of RV dysfunction because the right ventricle is not designed for the systemic work. And the bigger problem with this is that the management options are really limited. So kind of reading around this area, it's really, I think, a bit chicken and egg or a vicious circle. I tried to make a little schematic diagram to represent that. As the right ventricle fails, this, as I say, it progresses over time, but there's several reasons for that. There's reasons that are on this slide, including like the coronary anatomy, and if they've got rhythm problems, but the main underlying thing is that this systemic right ventricle, because some people refer to it as subaortic because obviously the aorta's coming from it, is supporting the systemic circulation, which it was not designed to do. So it starts to remodel and becomes very hypertrophic, and that means it dilates. And as that happens, the annulus of the tricuspid valve dilates. And when this happens, the tricuspid valve, which is on the morphological right ventricle on the left, begins to become regurgitant and there's malcoaptation of the leaflets. And as I say, that means the ventricle dilates further, and my understanding is that just results in a bit of a vicious circle. If that valve is already abnormal or to some degree dysplastic or epistenoid, once this process starts, I think it's a rapid decline for these patients. And if there's a VSD or this regurgitation, that volume loading of the right ventricle just gets worse because there's more pulmonary blood flow, and then it worsens, and then, as I say, that cycle just continues. On top of that, as I mentioned at the beginning, the septum's often malaligned, and that malalignment then worsens further. That's got implications for conduction abnormalities. So sometimes if there's some outflow to flow from the morphological left ventricle, so that's the pulmonary flow, then that can reduce the amount of pulmonary blood flow, and that is actually kind of a helpful thing. It's protective. It means there's less shift of the septum and a bit more equalisation of pressures maybe. So that means that the morphological right ventricle on the left geometry improves, and that can be a bit protective against getting further tricuspid valve regurgitation. I hope that makes some sense. It's quite wordy how I've put it, but just trying to explain what actually happens. So the key point is that when this valve starts to, when there's malcoaptation and the valve's becoming regurgitant, it's important to watch that and replace it early before you get worse along this pathway and this cycle of a worsening right ventricle function, and that is in the ESC guidelines as well. So this picture is probably not helpful, especially because it's not labelled the way I've been discussing, but it's just showing that you're getting regurgitation across the tricuspid valve, and that's one of the key things you're watching for as well. But MRI is really helpful in these patients. Firstly, you can really see that the right ventricle on the left is a right ventricle by the trabeculations. You can see it starts to become dilated and hypertrophied, and then you see the changes to the septum. So that's MRI gives extra information there. Once you've got this systemic right ventricle beginning to fail, the option's really challenging in the older patient. Some people use at the age of 15, but I think really it's case dependent. But after a certain point, they're not suitable for an anatomic correction anymore. So at that point, you're looking at palliative ways to improve function or delay deterioration. So focusing on things you can actually help with. So the options really are pharmacological treatment initially, so you can reduce afterload with ACE inhibitors, etc., and you can reduce preload with diuretics, or you can use inotropes. And then you start considering, is there a role for PA banding? So as I was trying to explain before, if you do have some pulmonary outflow obstruction, that can help with improving it can help decompress the left ventricle, and it can help the septum align better and reduce the progression of that tricuspid regurgitation. If that doesn't seem to be the problem, but there's still symptoms of dysfunction, then sometimes it can be helped with using cardiac resynchronization therapy, so pacing, and that's more used if you're starting to get a widened QRS duration. And then after that, really, you're looking at ventricular assist and thinking about going down the transplant route, which obviously is difficult with a limited number of donors. So, and then the other thing, going back to this side, is thinking about replacing the tricuspid valve early to see if that can improve things or delay progression. So that is in the ESC guidelines. It's not the strongest class of recommendation, but it is recommended to consider early replacement. I think that's one of the things I've taken away from reading around this. So the conduction system abnormalities, kind of doing it separately, although it's all together, they can be there from birth because you have abnormal positioning of the sinus node, and then you can have two AV nodes, but maybe neither of them are functioning normally. So you can start early in life with an AV block, or it can be something that occurs as you're having changes in, like I say, about this septum moving, or if you've got an epistenoid valve and your atria are dilating, etc., you can end up getting atrial tachyarrhythmias and things. Heart block, arrhythmia, sudden death in this group of patients is one of the main concerns as well. There's 5 main congenital heart defects with the greatest risk of late sudden cardiac death, and this is one of them, the other being TGA, tetralogy of Fallot, aortic stenosis, and univentricular hearts. So we do say sudden death, but it's part of the follow-up of these patients to try and be aware and monitor for changes in the conduction and things that we can help with. Commonest arrhythmia is normally the just spontaneous AV block for the reasons we were discussing, and then patients that have had surgery, I've just used the plus signs to say how common they are. So the spontaneous AV block is the most common, and then the surgical AV block or Parkinson White. And then you do have various other things. You can have flutter or AV re-entry tachycardias or atrial fibrillation, and then obviously the BT and sudden death. So looking at about a third of the patients ending up with AV block. It's a bit rare in children, it's about 8%, and then can present in birth, but every year that goes by there's a 1 to 2% increased risk of developing AV block. This slide is just talking about the coronary arteries, because as I said at the beginning, the failure with the right ventricle, as well as the reasons we've discussed, it's not helped by the fact that the coronary artery anatomy is not ideal either. So just as the ventricles are inverted, the coronary arteries are inverted as well, meaning that the morphological right ventricle on the left is supplied by a single right coronary artery, and that means that as this ventricle becomes hypertrophied, has more myocardium, it's just inadequately perfused by the single coronary, and so you have mismatch in the perfusion and demand of that myocardium, so this becomes ischemia. I suppose that also contributes to areas of ischemia will mean the myocardium becomes a bit dysynchronous, which is why resynchronization therapy can be helpful. So monitoring for that in adult patients is important, and ways to do that with an exercise test or perfusion test or a dobutamine test, but also there's a big role for cardiac MR in this as well, and using late gadolinium studies you can see if the myocardium is becoming ischemic or even infarcted, and if there's scars, and that is seen in about 40% of systemic right ventricles in adult patients. That's a kind of cardiac CT just showing that the right coronary has become hypertrophied and it is supplying that morphological right ventricle on the left, which is quite a hypertrophied muscle, probably needs better blood supply. So, just mentioning CMR, I know we had some talk on this last week from FU, but focusing on children. In adults, it's just becoming increasingly importantly used for assessing the function of the right ventricle and tracking its size and function. Obviously, it's limited to patients without pacemakers or other contraindications, and some patients might just find it very claustrophobic, or they're not ideally suited to having an MRI. But it means that you can look at the volumes of the right ventricle, and if the volumes reach a threshold of more than 150 mils per metre squared, that's indicative of poor prognosis, and these patients are more likely to have early mortality, severe failure, have tricuspid regurg and other events. And again, as we said before, you can also use MRI to do stress perfusion and late gadolinium enhanced scans to look at what's happening with the perfusion and if there's any coronary artery stenosis. Just talking about the follow-up and kind of summarising what these patients need. As I say, it's a rare condition, but they're an important group of patients. They need follow-up really every 6 months, year, 2 years, need regular imaging and things. So the big risks are developing the right ventricular failure. And that's why we need to do exercise tests and preferably cardiac MR. The other thing is that before they become symptomatic, you want to be detecting subclinical dysfunction. So using slightly less crude techniques than just straightforward echo, so doing performance indexes, maybe looking at tissue Doppler and tissue displacement, and doing some strain analysis on the myocardium, sort of for regional abnormalities as well. And then also important to keep an eye on the tricuspid valve, and if it's becoming regurgitant, and look for early intervention on this valve as it becomes regurgitant. So if the patients have had surgery before, they're more at risk for adverse outcomes, and the other thing is watching out for the conduction problems they can have. They are at high risk of sudden cardiac death and also developing heart block, so make sure they have regular ECGs and exercise tests. And then, I know I didn't really talk about the patients that had early surgery, but just in terms of a follow-up, their long-term survival is quite good. It's well over 50% anyway. However, slightly increased cause of death, and that can be when they have repeat surgery or the risk of sudden death, as we've said, and the higher risk of MI, arrhythmias and infections. So patients will need reoperations, quite a high number of them, 80%, normally for the valve, or if there's been a conduit that's failing or conduits need replacing, as we know from our work here, I guess. And about a third will need some intervention on the valve. And just a little summary on the European guidelines, which is really what we've said. They need lifelong follow-up, and the reasons why. ACE inhibitors are used a lot, but without much particular evidence behind them. And then sports, there is limitations if they are advised not to take part in competitive sports or static sports. I assume that means like weightlifting and things. Once they're starting to get decreased systemic function, then they should really restrict their sporting. And there is specific guidelines for pregnancy and pre-pregnancy planning. So there is some genetic association with ccTGA, but it's not really clearly known, and it's not really thought to be a condition that particularly reoccurs. However, the risk to a mother who's got ccTGA, if they've got ventricular dysfunction already, is quite high, and in the guidelines it says it's contraindicated, which is, pregnancy is contraindicated, which is probably a difficult way to phrase it, but they would need some pre-pregnancy planning, and it might be thought to be very high risk for some patients. Antibiotic prophylaxis, again, this is from European guidelines. So anyone with a prosthetic valve with any residual leak, any cyanosis, or if they've had previous endocarditis does need antibiotic prophylaxis. Obviously, we've narrowed the indications for prophylaxis over the years, but there are still a group that need that. This is just a summary, really, of the things I thought were the key points. So, firstly, that these patients may be presenting to adult clinics for the first time and not been previously diagnosed, and the risk of sudden cardiac death is high and important. So they probably need to know about the risk of arrhythmias, and that should be part of the counselling when you're talking about sports as well. These patients with a systemic right ventricle who are developing failure are the big challenge to treat, and to try and optimise their kind of function or delay progression of that is the most important thing. They're probably not suitable to have an anatomy repair. And then it can come to the case where heart transplant's the only option, but trying to be a bit more positive. Most of these adults with this do have a full-time job or study and have a fairly good quality of life, so it's not all gloomy-ish, and that's it. So that's it. Any questions or anything, comments?
Yeah, that was, Sophia, that was really good. I think it's a very difficult topic, as you said earlier on, that because it's not a lot of papers to do the follow-up of ccTGA, because many of them might be lost in the community and we don't know that they exist, and the management has been so different. There was a review from Toronto a few years ago, which was very interesting, which they review physiological repair, anatomical repair, and then doing nothing, and then comparing with an equivalent Fontan group with left side dominant group. Have you come across that paper? Do you think that that's, because that gives us an idea about 35 years follow-up of this condition?
I don't think I saw a few papers when I was reading around this, but I didn't find anything as clear as that. And as I said, it was anecdotal when I spoke to our cardiologist that, you know, when you read it, says it's very rare to have any to do okay by having a systemic right ventricle, but both of them sprung to -1 that did. So it would be nice to actually see, and there might be people we just don't know, like you're saying. So to accurately know that, it's always difficult to know what we're doing in childhood, where we're going with that, and what is actually the very best strategy. It's so difficult to know. And this group's really difficult because if they were asymptomatic and they didn't have ECG that flags something up, in fact, you could miss subtle ECG findings. We've got so many, and or a subtle chest X-ray. They might present in failure or have an MI and never be diagnosed. So there might be an early death that's not known. I think it's a condition that could be missed. I don't know what you think.
Yeah, no, I think that's the difficulties of managing these patients, I guess, because many of the management will be prophylactic, because some patients are not symptomatic, and what we're trying to avoid is for them to fail in 10 or 20 or 10 years time, something like that. And I think that's what made the decision making quite difficult to do. And either to do anatomical repair, physiological repair, or essentially the difficult ones, anatomically difficult ones, to transfer them into become a single ventricle root, Fontan type. Yeah, what the paper show, but is you need to read every paper to analyze it, is that probably the Fontan have equally, in the long term, they survive better, but obviously, and less intervention, but it doesn't mean that that's the right procedure for that. And it's a balance between when you offer anatomical repair, patients is very likely they will come back for another operations, including dilated for double switches. I think there is not an insignificant, it's about 10 to 15% of they come with LV dysfunction, regardless of whatever you do. So the next step is doing to actively retrain the left ventricle. But it's not an easy group to manage.
Well, there's Arnold's case yesterday in cath lab was the ccTGA who had VSD and pulmonary stenosis, so slight differences, but has had a Glenn. But then even now looking, I mean, obviously he's going to be presented at JCC, but that left ventricle doesn't look particularly, the morphological left doesn't look particularly adequate to take on the role. So you may be looking at a Fontan, as you're saying, and it would be worse in a way, wouldn't it, to go to try and do an anatomic repair and then fail there.
Well, one of the indications to look carefully about anatomical repair in this case is what's the status of your ventricular function already, and that's why the operations need to be timed rightly, under the age of 3, under the age of 5. But still, there's a lot of things that we don't know, I think, and it's because it's such a small group, and as you say, there's many people probably lost in the community.
Small group and wide variation within the group, and then being managed in different ways. So getting the actual data is very difficult to know, I suppose. Finish then.
Any other questions?
Hi there, Anand. Hello.
Yes, Anand, we're listening.
A quick question. When this morphological RV starts failing as an adult, do guys at times use VAD as a destination therapy if hearts are not available, or there are limitations to that?
VAD.
Oh yeah, that is in the guidelines for. So VADs are used, and then.
Well, okay, cheers. Because if you're saying the heart transplant remains the only option, but the lung should be pretty reasonable. So if you just assist with tons of devices now, isn't it, for adults, and that could be the destination, isn't it?
Yeah, I probably missed that step, but it is there for sure.
Cheers. Thanks, no problem.
Yeah.
Just a point on that. VAD as destination therapy is not an option in the UK. So
As a bridge, though, for.
yeah. But no. Destination therapy is in Germany, as far as I know, and in the States maybe. But I don't. As far as I understand, it's not.
Okay.
Destination therapy. VAD therapy is not an option.
Okay.
So after reading all that, Sophia, what do you think that we should do with the patients? Should we look for them, or should we retrain them?
There is
Or in the adult
feeling
side?
that it's, picking them up late is after the horse has bolted if they're presenting with symptoms. Because an early pickup, you could have an anatomical repair, which may be the best, I don't know, but I think it's probably on us cardiologists to be really finding the patients if they're early.
So it seems to be the ones that if we diagnose them as adults, the options are, there's not many
I
options.
think PA banding is a good option from what I've read. It does seem to improve things and definitely delay progression. And I think that's the option I'd be saying. Case by case, obviously, but it even can prevent, if it's preventing further septal deviation and problems, you might end up with the conduction problems and maybe. What do you think?
No, the natural history will tell you, and the natural history of all of them will go, and I think that probably our role as in the pediatric side before moving to the adult side is diagnose as many as we can, and then formulate a plan and probably counsel the family, because the decisions need to be taken probably in the first 5 years of life. What kind of are you going to do anything, and if we are going to do anything, whatever is the technique.
I think the incidental findings in adolescence, that's really difficult.
It is very difficult.
Where to go there? They don't have any symptoms, they feel perfectly fine, and then you're describing a situation which is a bit gloomy, isn't it? To be told this one can be gloomy.
Yeah, it is, because even after a perfect whatever operation, it is very likely that they will need another operation. It's very likely a compromise. But it's the usual balance, the risk and benefit balance of life in our specialty. Is either you want to be alive at the age of 60, or you want to live well for only 10 years. And the compromise is that you need to come to the doctors and have multiple operations. And I think that's the brutal decision making for a patient, I guess.
It's just always, I've seen one late diagnosis in Manchester, and poor person was in for oncology, so it's a double bad situation. But I think when you're starting off with, now we've got antenatal diagnosis, early diagnosis, it's difficult, but the root's there. It's always hard and out of the blue bolt to someone that's not expecting anything, isn't it? But yeah, they might be a bit more time to think and make those decisions, because it's not an emergency, is it? It takes some time.
On the positive side, there is some probably very good solutions at the moment that some of them benefit, some of them do not. Sorry, Shri.
No.
Finished, I think.
Yeah. All right, thanks. If there are no other questions, we'll thank Sophia and end the session.
I will ask a quick question, Shri Nayan here.
Yeah, please.
Thanks, Sophia. Very, very good presentation. Considering that this is a very rare condition, and obviously nobody has enough experience, I just wondered, is this something that's captured in a national registry, to collaborate and to collect data within the UK? Is there a national registry for ccTGA to share experiences between units?
I don't think there's a specific ccTGA registry that I'm aware of. I don't know.
From the cardiology, you mean?
Yeah.
The cardiology, I'm not sure if there is a register. No.
I don't know.
But we need to ask. I don't know. Rob is sitting both sides, so I don't know if he will know.
If there isn't, Sophia, this is a good start. You can start one.
That's a good idea, Nayan.
Well, I'm going for adult experience in September, so maybe see how many people are coming through their clinics, and it's quite.
So you can create a WhatsApp group of ccTGA.
I suppose the other place you'd see is pacing clinics and things. You get an idea of. I don't know.
Brilliant.
In pediatrics, for very rare conditions, there's something called the British Pediatric Surveillance Group, which tries to assimilate and collect information from everyone. So this certainly sounds like one condition that needs all the units to collaborate, really.
Yeah, I'm aware of that. That'll be good.
Yeah.
Okay. So it's the end of ccTGA now. Hopefully we're moving on to something less complicated from next week.
All right. Thank you guys for joining for the session, and thanks Sophia for the talk. Bye-bye. See you next week.
I am getting the prize for the most attendance.